Well, it's a cold day in February. I'm sitting by a fire and I'm getting ready to talk to you about the respiratory system and also an awful lot of clinical aspects of the respiratory system. This is, I think, the last lecture on the respiratory system, and that is also then the last lecture for lecture exam 2. At this point, this is February 5th for me. Your lecture exam 1 is in 6 days. So chances are you aren't listening to this until after that first lecture exam. And if that's the case, I hope that you've looked at the lecture exam and thought about what you wished you had done differently. The amount of material compared between the first and second lecture exam is pretty similar. So please look forward to doing about the same thing or the same amount of effort. I hope you find today's lecture particularly interesting. It's talking about all sorts of damage that occurs to the respiratory system and helping you to understand those types of disease. These are very common disorders. And if any of you go into healthcare, whether it be at the physician or the PA or the nurse practitioner or a nursing level or another level, like a respiratory therapist, these will be very common terms that you'll hear and problems that you'll see with patients. In large part, as you're going to learn, these kinds of problems, not all of them, but many of them, come about because of our own behaviors. So I'm going to end by talking about some of that. All right, functionally now, we've made our way down to the alveoli, and we thought about the alveoli as the functional surface. It's that very, very high surface area region, the terminus of where you inhale. It's the end of the hallway, if you want to think about it that way, not going down a hallway or a dead-end street. And the alveoli have tremendous surface area, and they also have a very, very thin surface that allows gas exchange to occur quickly through the cells into the blood system, into the blood supply, where oxygen and CO2 are transported. As we breathe in, I mentioned before that in the bronchioles there is smooth muscle. And so here they're looking at tightened muscle bands here in the case of someone with asthma. And what we're saying is these tubes leading into the alveoli are narrowed, they're restricted when this musculature is tightened. Also, excess mucus might close down the respiratory lumen and reduce the amount of airflow in and out to the alveoli. So this is one of the problems with asthma. As I'm talking about the respiratory system here, I will not be spending any time looking at the consequences of COVID infections. But boy, oh boy, what we know is COVID, the virus, has been affecting the functional nature of this respiratory pathway in many different ways. So it's possible that some of you are inspired to go read more about it after you learn about the respiratory system. When I read clinical studies about what is actually happening to the respiratory pathway and why it is that oxygen absorption and transport are so greatly reduced, it includes discussions of all of what I'm going to be talking about here. So, one factor affecting airflow, which is the title over here in the upper left, is there can be increased resistance to airflow, to breathing in. And the increased resistance, which has the effect of decreasing airflow, is this narrowing, okay? So instead of breathing through a wide open pipe, you're breathing through a narrow pipe. And maybe the way to relate to that is trying to drink through a very big, broad straw, the kind that I'm familiar with at McDonald's, or a very narrow straw, and I'm not sure where you're going to get these very narrow straws. So there are two main factors that influence airway resistance, that is, reduce the amount of air that you can get into your lungs. And I've just been talking about the bronchial diameter. That's what we're looking at right here, the diameter of the bronchioles, okay? And in bronchoconstriction, we have this decrease of the bronchus or bronchiole. And why do we have this? Well, it could be that it's some kind of reaction where histamine has been released and has this effect. Parasympathetic nerves, cold air. So some people with asthma may notice that when they go out into a very cold day like today, when I woke up at about 6 in the morning to try to actually get some fires going, I have a wood pellet stove. The temperature this morning was -1. -1. Thus, I'm sitting next to the fire with Zoe here and Lucy around the corner. If I had asthma and I went out in a day like today, we could expect it to be even more difficult to breathe. Okay, so bronchoconstriction could be a consequence of cold air, and of course, if you already have asthma, this is going to be a serious problem. It might be that you breathe something that might even make you cough and have some kind of chemical irritation. And again, that's going to trigger bronchoconstriction. So what is the consequence? It decreases airflow to the alveoli. And if you have a bronchoconstriction severe enough, you can suffocate. You can literally die. And so we have to be very, very careful about this. Bronchodilation is the opposite of bronchoconstriction. And that's when it gets easier to bring air into the alveoli. And what might cause this? Well, a hormone, a stimulant called epinephrine, also known as adrenaline, will cause the dilation. And if you think about this as part of the fight or flight response, what this is doing is allowing you to breathe more easily. So part of the excitement of the fight or flight response is getting you ready to fight or flee. And I'm a flee guy. I think that that's better to avoid these kinds of situations than to confront them. And I think police and many other people would suggest if you can get away from a violent situation, it's much better than trying to fight your way through it. So you get increased airflow. This is all a consequence then, getting the fight or flight response is getting you ready to run for your life or fight for your life. Now, I said there were two factors influencing airway resistance. We were just looking at the size of the bronchioles. The secondary factor influencing, again, airway resistance is called pulmonary compliance. And what this is the ease at which the lungs can expand. Okay? How easily can we inflate those alveoli? As we're going to see more and more here today, compliance, the ability to stretch, the ease at which it stretches. Let me help you to understand that idea of compliance. And I just thought of this. I have socks, some kind of socks, that when I put on, oh my gosh, I really have to work to stretch the sock to get my foot inside. And I have other socks that I probably should replace, in which the elastic is not all that good, and they're kind of flimsy socks, and you can slip them on real easily. Okay? Well, that's what we mean by compliance. How easily is it that the lungs expand? And what we're going to see is that there are a variety of sad, degenerative lung diseases in which there's scarring of the lungs and the ability of the lungs to expand is reduced. That's not good at all. And I am aware that that is one of the consequences of having a really bad COVID. There could be some scarring and there could be lifelong damage to your lungs. Another aspect of compliance is remembering that idea of surfactants down here, surfactants. And what we were saying was, like in that Walmart bag, if there's water inside the bag, that the sides of the bag are sticking together. And we said something like a soap would help those two sides of the bag to let go, to free themselves up to stretch open. And so this compliance is limited then by surface tension of the water inside the alveoli, and you need surfactants to break up the surface tension. So again, how easily can you inflate the lungs? Well, in part, are those alveoli stuck together? And second, are those alveoli stiff because of scar tissue or nice and pliable? Now I want to talk about a different aspect of getting air into the alveoli, and have you think about now some of the parameters of the actual respiratory system. And I remember when I was a kid watching, various movies of people surviving, and they'd go underwater and breathe through a straw. Okay, so they'd be hidden underwater, but they could breathe to the surface through a straw. And what I want you to know is you can't do that for very long. And here's why. Really a couple reasons. One, it's hard to get much air through a straw like that. It's very narrow. So certainly if you're grabbing some plant, and there are some plants that you could do this with that's sort of tubular, boy, they'd have to be a plant that's wide open and doesn't have little particles that are going to break free and be inhaled into your lungs, because that would cause you to cough, and that would defeat the system. But the second problem is the idea of dead airspace, and we're going to explore this a little bit. When this person exhales, you need to know that that tube is filled up then with exhaled air. And when that person breathes in, the very first thing they're going to breathe in is exhaled air. Now that same principle of this dead air that you breathe in first, the air you were breathing out, is occurring in our own respiratory system. All the tubes leading to and from the alveoli are not flushed completely. In all those bronchioles and in your trachea, as you breathe out, that air that you're breathing out now is the first air you're going to breathe in. Okay? So that's part of the trouble. If you really wanted to demonstrate this, you could get a long paper tube, the kind that usually Christmas wrapping paper is in, the kind of stuff that might be 30-inch long tube. And you can plug your nose and just breathe through that tube, probably sitting down, because you could become really lightheaded really fast. And as you breathe out through that tube, it's filled up with the air you just breathed out. And now as you breathe in, you're going to breathe in that air you just breathed out. And what you will find is at least two things will happen if you're breathing through such a long tube. One is you'll take more breaths. You'll breathe faster in and out. And the second is it might not be enough and you get lightheaded. And you could try this. And I did try this when I learned about this, probably in high school. And I was very impressed because it was quite the demonstration. Okay. So adding extra dead air space like this is going to make breathing very, very difficult. Okay. So let's talk about these alveoli and consider the dead air space as we're moving along. Only the air that's in the alveoli is functionally there for gas exchange. Okay. Not all air that's inhaled gets there. So about 150 mLs fills, as it says, all the passageways to get to the alveoli. And this is what's called the anatomical dead air space, or anatomic dead space. And that's this conducting part of the airway where there's no gas exchange. And that's what I was just saying. When you add on a tube that you're breathing in and out, you're adding it on past your mouth. You're just adding on to the length of the dead airspace, and this number from 150 could, with one of those tubes from Christmas paper, oh my goodness, could quadruple this number easily. Okay, so think of the volume of those tubes. Just look at a tube you use for paper towels, and that would greatly increase it. So what do you think the volume is of a paper towel tube? How much water could fill that? And I don't know. I'm looking at a drinking water bottle. It's about a pint. It's about 500 mLs. And I would guess easily that one of the tubes for paper towels would be about 300 mLs. So that would triple the normal dead air space. Okay. So this dead air space, we've said already, can be altered by innervation and by the constriction, by the bronchodilation or bronchoconstriction, okay, that we just talked about. So that would increase or decrease the dead air space. If you have bronchodilation, Is that going to increase or decrease the dead airspace? Bronchodilation. Sounds like a good idea when you're exercising, but in fact it increases the dead airspace. So you can get more air in and out, but you also leave more in between. You also leave more in the dead airspace in between. This is just some basics. There's a lot of terminology here in the next 5 or 10 minutes, and you want to get a lot of this out of the book. So if I were you, I would not be writing these things down. I'd be finding where in the chapter, probably early in the chapter, maybe 22.2, section 22.2, you're going to see an awful lot of these terms. So maybe just listen and think about the terminology here, and then you'll get lots of these boldface terms that are here in the lecture and also in the textbook. You'll get those written down as terms to learn, and I hope you have a way to quiz yourself over that. So a person might take a breath, a normal breath of about 500 mLs of air, of which about 150, we said, stays in the dead airspace. And that means about 350 mLs of air with every breath are making their way into the alveoli. The alveolar ventilation rate is simply, okay, if this is each breath, how many breaths a minute? And we said before, maybe 12. And so for those of you that had calculus, 12 times 350, well, how do we do that? There's the answer. But 10 times 350 is 3,500. 2 times 350 is 700. So 3,500 plus 700 is 42. And that's how I do this kind of math in my head. So that's the amount of fresh air going over the alveoli in a minute. And as it says, this measurement is very important to your ability to get oxygen to the tissues and get rid of carbon dioxide. Meanwhile, your residual volume is then about 1,300 mLs that can't be exhaled and that aren't going to be going out. Here's a way that we measure such things, and in a clinical setting, and if you are having respiratory problems, we want to assess. We want to learn, okay, what are your capacities? What is it that you're doing? And by the way, in this figure, why do you think they're pinching the person's nose? Why do you think they're pinching the person's nose? And I hope you said, well, so they don't breathe out their nose, because this device is trying to measure all of the air that you're breathing in and breathing out. And if some of the air was coming out through your nose, well, then they wouldn't be measuring all the air that you breathe in and breathe out. So a technician, a person who's running such machinery and making such measurements, would have to make sure this is really clamped tight on the nostrils. And that's it. For a normal, healthy person, the only two ways you get air out of the body is through the mouth or through the nose. So what we just looked at is spirometry. It uses a spirometer, a device here that you see is capturing what you're breathing, and it's recording lots of things. How frequently you breathe, how deeply you breathe, the speed at which air moves in and out. So do you slowly inhale? And I deliberately was trying to make sound there because I want you to know I just took another deep breath and it didn't make a lot of noise. So, so he's okay. It's also measuring how quickly you're using oxygen, okay? And so here's a few bits of terminology we're going to see on the next slide. I told you there's lots of it. When we said each breath was about 500 mLs, that's called the tidal volume. And that's how much air is moving in and out past, if it's just your nose, past your nose with every breath. And then we said times about 12 breaths a minute. And this is if you're at rest. Perhaps if you're just sitting around or standing around listening to this, then you're breathing at about this rate. We said then that that's the normal, relaxed kind of breathing. But how much more air could you breathe in with your maximum effort? Air in excess of tidal volume that can be inhaled with maximum of effort could be up to 3 liters of air. Wow. So when we say take a big, deep breath, we're talking about a breath that's maybe 6 times 6 times what you'd normally breathe in. Okay. And once you breathe out, how much more could you exhale? Okay. So maybe you're trying to blow out a candle or start a fire. Starting a fire is on my mind right now as it's so cold outside. And yes, I have a furnace in the house. I just like burning and fuels and things that are renewable. So I don't like fossil fuels for generating my heat. I like burning wood, which we grow again and which recycles the carbon. Expiratory reserve volume then is the extra amount you can breathe out to start that fire, or maybe blow out those birthday candles, not Christmas candles, birthday candles. And I was just listening to somebody selling a product, by the way, about blowing out birthday candles. And they were talking about the phenomenon. Not sure if you ever thought about this, but you're at a birthday party and someone's going to blow out the candles and then they're going to serve the cake. Well, they just blew all kinds of spit on top of that cake. Is that really the cake that you want to eat? It's a little gross. So they had a product to help you blow out candles so you didn't spit all over the cake. And I hadn't really thought about that, and I'm an old guy, and I should have thought about that. And now it's a little creepy for me to eat a birthday cake that somebody just spit all over. Sorry, I didn't mean to ruin it for you there, but maybe you can find another way. So somebody said that maybe what they did was put candles on a cupcake. They had a birthday cake, but they made a cupcake on the side so that the person could blow out the candles on the cupcake. Maybe that makes sense. Anyway, so this is extra you can inhale, and your maximum extra you can exhale. And so when you do this, by the way, have you completely emptied your respiratory system? Is everything collapsed? No. The alveoli are not collapsed, and your bronchioles and your trachea is not collapsed. In fact, what we talked about over and over was the cartilage that actually keeps the bronchioles and keeps the trachea wide open. So no, you aren't exhaling everything. Here now is a nice chart. So if you looked at a spirometer and the kind of things you might measure, this is the normal tidal volume. This is the 500 or so. So that's the difference between 3,000, 2,000, split the difference. That's about 500 mLs of you're just breathing in and out right now. You're listening. And then you take a big deep, let's see, in this case, you exhale to the maximum. And that's showing you're exhaling to the maximum. And over here, you're inhaling to your maximum. So I had talked about just before in the prior slide, just to show you, we talked about tidal volume, inspiratory reserve, that's inhaled reserve, and expiratory reserve, that's exhaled reserve. Here's the tidal volume. Here's how much extra you could breathe in. Here's how much extra you could breathe out. But notice that after you breathe out all that you can, there's this residual volume. And that's what I was just mentioning, that you can't collapse your bronchioles and your trachea. And so there's always some air left over in those tubes in your system. Well, that's not the only terminology. Here we had tidal volume, inspiratory reserve, expiratory reserve, residual. We just talked about those. Okay? And now we have some other terms right here about capacities. Your vital capacity, the amount of air that can be inhaled and then exhaled with maximum effort. Okay? So what would that be? Well, if you look, it's how much extra can you exhale right here, and how much extra can you inhale? And 3,000 is how much extra you could inhale. 1,200 is how much extra you could exhale. And if you look and add that to the tidal volume, all those together come up to 4,700. Okay. What's your total inspiration capacity? 3,000 plus 500. That's right here. How much total could you have in your exhale part? Well, it's the exhale part plus the residual. Okay, and so the total maximum amount of air in the lungs, you're adding this all together, this 3,500 and 2,500 maxes out to 6,000. Here in 22.3 is an awful lot of respiratory terminology and also word roots over here. And boy, I think this is going to be so much easier if you add in these word roots. So you see over and over PNEA, 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 PNEA. Why don't you learn what PNEA means? It means breathing. A, apnea, temporary cessation of breathing. Well, if you knew those two words without breathing, I think you could guess the definition. Okay. Dys, difficult, abnormal. Dyspnea, labored or gasping abnormal breath, shortness of breath. Hyper, above. Regularly when I describe this, I tell you that what annoys most of us are hyperactive kids, right? But nobody seems to be annoyed by hypoactive kids, below normal activity. So hyper always remember is extra. Hyperpnea, you're breathing more than usual. Okay. Hypoventilation is below normal. Okay. Other kinds of respiration down here. Tachia, fast. Ortho means straight. So this is orthopnea. Here is when a person's lying down or any position other than standing or sitting. And this is then orthopnea, so it's the person's position. Okay. Anyway, this is the kind of thing, if you go into a clinical program, guys, you're going to get an awful lot of this. And why? Well, these are the terms that are going to be on a medical chart. And you come in and look at the chart, and maybe you've just come into a new shift, and you're going to see who your patients are, and you've got some new people, and you look at their chart, and it has these kinds of terms. Well, you darn well better know what it is that the patient is suffering from. All right, that ends our look at chapter 22.2. 22.3 is all about gas exchange. It's the chemistry of gas exchange. And it's lots of details, and boy, it's important details of the physiology of gas exchange. But I'm not going to talk about it because it's those kind of things that are best seen from the textbook. It's not a big picture kind of thing. It's the technical details of gas exchange. So I'm not going to discuss it, and I'm going to skip on to section 22.4. But here are the learning objectives for 22.3. So we're talking about partial pressures, right? The mechanism of transporting oxygen and CO2 and factors that are going to affect that, right? And discuss the effects of blood gases and pH on the respiratory rhythm. These are all really important clinical kinds of factors that are affecting the treatment and therapies, but they're not something that I think needs to be discussed. So I'm going to try to do more big picture things in lecture. Well, just talked about some problems, and I want to talk about some of them. Hypoxia, which is a deficiency, is exactly what the consequence is of COVID. And so I don't know if you know about pulse oximeters, but it's a little device, kind of looks like a clothespin, that pinches on your fingertip, and it's measuring how much oxygen is in your blood supply. And we would hope that it's somewhere about 98, okay, of maximum saturation. It'll also measure your heart rate, so the number of beats per minute. And when COVID first happened, one of the first things that I had learned as we were learning about the disease was that people were developing hypoxia really, really quick. And they were going to the hospital, and they were having huge problems breathing and getting a sufficient amount of oxygen. Okay, well, so that's to be expected. But then a few months in, and this is still summer of 2020, what we learned were some people at home with COVID were really, really hypoxic. They had very, very low oxygen levels, but they didn't know it. And so what we were seeing was the first recommendations in the literature, that is the scientific literature, that people who get COVID would benefit from one of these pulse oximeters so that they would know while they're sick just how bad are they and when they need to go to the hospital. Because it was, again, the case that some people with COVID were hypoxic but didn't know it and needed to be at a hospital. So right away, this is what an education gets you. I went out and bought 2 of these pulse oximeters. One in case I needed to lend it to somebody, a family or a friend or a neighbor that needed to know these kind of things, and one, of course, to keep for ourselves. So this is what I've been doing. I've been keeping up on these things, and so I've had one now coming up on 2 years. I've actually had 2 of them, so that I could measure this in case we get a serious respiratory infection and we aren't aware that we are not getting enough oxygen in our system for our tissues. So there's different kinds of hypoxia. In this case, you aren't getting enough pulmonary gas exchange. This is exactly what we were talking about for COVID. It's also what will happen if you go to high elevations, or if you're having trouble breathing, or if there's something blocking your respiratory passageway, or you stop breathing, or you have some kind of degenerative lung disease that we're just about to talk about, or carbon monoxide poisoning. And carbon monoxide is generally a gas given off in some kind of inefficient combustion. It could be from a car engine. And so if you're running a car in a garage, with the garage door open even, the fumes could still accumulate in your garage. They could seep into your house. Carbon dioxide has no smell, and it creeps up on you. This kind of hypoxia creeps up on you, and you don't know it, and people often die of this. So if you have that kind of risk, or if you have the use of natural gas in your house, the use of natural gas, which is really common. So if you got a gas stove, you ought to have a carbon monoxide sensor. And so in addition to the smoke alarm, you want a carbon monoxide alarm. Now in our house, we are all electric. We don't have any natural gas. And I'm always aware that when I'm running the car, so in the winter with horrible temperatures, did I mention to you that it's really cold today? In these really cold temperatures, you might be tempted to warm up your car while it's in the garage, and I don't do that. So in the wintertime like this, I back out. It's usually the morning, there's sun shining. I'm going to get a little bit of sunshine heating up the car, and I back it out so that I don't get the car fumes accumulating in the garage. These are all just good things to think about. Ischemic hypoxia, as it says right here, is because your circulatory system isn't working. It's inadequate. Anemic hypoxia, as you would guess, is a problem with your blood supply. You have anemia, right? And so you don't have a sufficient number of red blood cells, or those red blood cells are somehow diseased. And one of the things red blood cells do when they are maturing is they lose their nucleus. And so if you think about it, if you have a disease where the nucleus is not lost, or it's not lost quickly enough, then those red blood cells are going to be reduced in their oxygen carrying capacities. Histotoxic hypoxia right here are poisons. So this could be cyanide gas, for example, that is going to prevent you from carrying the oxygen. And finally, cyanosis is not a type of hypoxia. It's a condition. It's a sign of hypoxia in which maybe your lips look blue, the palms of your hands. We all vary in our skin pigment, and so sometimes darker skin might be a little tougher to see the hypoxia. But cyanosis might show up in the palms of the hands, which tend not to be pigmented. How about breathing extra oxygen? Does that seem like a good idea? So the Super Bowl's coming up. Chances are Super Bowl's already over, and you already know who won the game. And on the Super Bowl, I've noticed in other Super Bowls or even in other football games, I'll notice that players who are really tired, they've been very active, come to the sideline and somebody puts on a mask and they're breathing pure oxygen. That might help for a little while, but you can't do that for a really long time. And the problem is if you do this for a long time, especially if you do it at a higher atmospheric pressure, here's the kind of consequences. And they aren't good. Free radicals are generated. I, we're destroying enzymes, or hurting nervous tissue, and as you can see, it could lead to seizures, coma, and death. So when divers go down and they want an oxygen supplement, you know what's in their tanks, they're breathing a mixture of oxygen and nitrogen. I don't know if you know right now when the air you're breathing, if you got good fresh air, but how much oxygen would we expect in that air, in atmospheric air, and how much nitrogen? And the answer is about 78% nitrogen, about 21% oxygen, and if you add those two up, that's 99%, leaves you 1% for other gases. Hyperbaric oxygen is this. It's at a higher atmospheric pressure, and so we were really getting oxygen into the tissues. But for premature infants, it was no longer used because it was causing this retinal damage. Hyperbaric oxygen is used under certain circumstances, and you can read about that on the internet, actually. And now that leads me to really, at the end of the lecture, we're going to look at a series of chronic problems, like asthma, okay? COPD, and you might have seen advertisements for drugs related to COPD. You should learn what this is an acronym. So an acronym is where we take the first letter from all the words and make it into another word. So COPD, chronic obstructive pulmonary disease, is a problem then with airflow. Okay? It's the ventilation, getting the air to and from the alveoli. There are different causes of COPD. One is chronic bronchitis, in which we have a chronic irritation of the bronchioles, and the other is emphysema, and we'll talk about both. But you should know that almost always both of these are associated with smoking. Now, in addition to damaging your lungs with smoke, it could be that you live in a very difficult place for air pollution. And boy, I experienced that when I was in China. So about 10 years ago, actually a dozen years ago, I was in China and I was in Beijing. And goodness, you could see the air in downtown Beijing. Right now, the Olympics are going on, and they have problems with air pollution there as well. They've had to really stop factories. They had to do this in the past in other Olympics, shut down factories and things because they pollute the air so much. And what I found was after, because I was there, I think, for 3 or 4 days in Beijing, I found that after days 2 and 3, my eyes burned, my throat burned, and there were all sorts of unhealthy things in the air. I would not have wanted to stay there long, and you can imagine if you're an athlete in those kind of conditions. You might also work in a place, your job might be in a place where you're exposed to irritants. It could be gasoline exposure, for example. And it's also possible that you've inherited something that makes these things more likely. In chronic bronchitis, and here you can just see and follow right through what's going on, is that you are regularly clearing your throat. Why? Because you have excess mucus. Those goblet cells get really big and you're producing lots of mucus. Unfortunately, the cilia that are moving, so remember that mucociliary elevator that was moving up the mucus, up your respiratory passageway? Those cilia are not working the way they need to, and the mucus stagnates. And this thick mucus is a place then the bacteria can grow, and that's really a bad problem. Smoking also can hurt the alveolar macrophage function, so dead and bad things accumulate like bacteria, and our ability to fight those bacteria go down with smoke, and you wind up with a constant cough. This is the kind of smoker's cough that I was talking about, but in this case, a person with chronic bronchitis is going to have that kind of cough for almost all the time. And so what could happen? You don't get enough oxygen, and you might have a bluish color to your skin. Could be a little lightheaded just as well. Emphysema is another type of COPD. And in emphysema, it's not the bronchioles that's a problem, it's the alveoli. And in the alveoli, so look at this diagram. This is from the internet. You don't have this. Here is a nice, healthy set of alveoli with lots of compartments. Almost looks like a beehive here. And then we break down some of those walls in emphysema. So the lung has fewer and larger spaces. That might sound like a good thing, but if you break down these walls, you've reduced the total respiratory surface area. So there's less surface area here for gas exchange. Further, the lungs become less elastic, and so as what you breathe in doesn't come out as easily, it doesn't collapse as easily, and air gets trapped in the lungs. People take bigger, deeper breaths to try to fill their lungs and try to deflate their lungs. It may also weaken then the chest muscles, so people are really gasping for breath. And here's a poor gentleman over here that's suffering from emphysema. I confess to you that I don't know what this is. It looks like a water pipe to me, but it may be a device that's helping a person breathe with emphysema. So, what do we expect for a person who has some form of COPD? The answer is their vital capacity is reduced. So they aren't getting as much air in and out. What it leads to is then low oxygen levels, high CO2 levels, because this is what the respiratory system is doing for us, right? It has a low blood pH because you got excess CO2, and you would have learned about that in section 22.3. And as a consequence of not having enough oxygen, we stimulate the production of erythropoietin, which is a hormone that's leading the kidneys. It's from the kidneys, and leads to this production of extra red blood cells. And we're going to talk about erythropoietin in detail and red blood cells when we next go on to the circulatory system. I'll just tell you that if you have extra red blood cells, you're a healthy person, but you have extra red blood cells. For example, you were training at 7,000 feet, which is where the United States Olympic, one of our training centers is located in Colorado Springs, then you generate extra red blood cells. And if you drop down to lower elevations, you benefit. You are actually able to carry more oxygen and usually perform better. So people abuse erythropoietin and can inject it into themselves to generate extra red blood cells and hopefully improve their athletic performance. And this is the kind of thing that Lance Armstrong was doing and others routinely have done to cheat. One thing about COPD, and this is the main thing, is over here, it's just plain old too little oxygen in the blood, too much CO2, and the consequences of that. The other is that the heart itself isn't working very well. So cor pulmonale right here is the enlargement of the right side of the heart. You haven't done too much circ system yet, but the right side of the heart is pumping blood to the lungs. And because the right side of the heart is working so hard to get good blood supply to the lungs, that right side of the heart is enlarging, and the whole system is failing because this is compensating. So let's review here. What is the most common cause of COPD? Well, this is an image that makes that point. A respiratory system filled with cigarette butts. Smoking, guys. Smoking. When you're young, you aren't experiencing too many of the consequences, although you aren't all that fit when you're smoking and you're young. But it's the toll that it takes on our respiratory system. Here, another internet site showing you that smoking is causing the alveoli to break down and the sacs are opening up more. We don't have the surface area. About a quarter of long-term smokers develop COPD. This is from the British Health Organization. Smoking doesn't just hurt lungs. It's leading to leukemia, other kinds of cancers. Smoking damages every part of the body. And this from the CDC. This is the same CDC that you're hearing about all the time regarding COVID. Look at just the long list. Blindness, a stroke, so a bleeding blood vessel in the brain, or a clogged blood vessel in the brain, which means part of your brain is going to die if it's not addressed. Long list. So I asked this question to you. I used this opportunity to ask this because I want this for you. I'd like you to live a long life, and I'd like you to have good quality of the years you have. So I'm in my mid-60s. I'm 64. And the truth is, guys, I walk 2.5 miles on just a walk with the dogs, not just what I regularly do in my life. I take those walks most days of the year. Amy and I did 235 walks last year in 2021, and 235 out of 365 is more than half. Okay? So we walk up and down hills, and we walk regularly. Our dogs stay in good shape. It's easy for me to breathe. When I lay down and go to bed, it's easy for me to catch my breath and relax, and I wish that for you. So maybe you too would like to live a long, high-quality life. What should you do? Well, this particular class is a very satisfying class for me to teach. And you know, in Human Anat and Phys, the first semester, I give you lots of advice. And I want to follow that through in the spring. And I want my students who are taking this class to not only be well prepared for a health profession, but I want you to be well prepared to live a long, healthy life. And I want one more thing. I want you to be so well educated that you share this kind of important knowledge about the quality of life and how to live a better life, a healthier life. I hope that you share this with your family and friends and those you serve in your occupations. So let's just give you the summary. This is not controversial, guys. Eat a proper diet. Here's sort of the latest way to say this. Of course, it's a lot of fruits and vegetables. Eating less meat, if you haven't heard that before, is a growing trend. And it's better for our earth. Producing meat contributes to global warming and contributes to pollution of our water. Now, one of the things I like to add here is, notice it says less meat, not no meat. What I ask is that you simply think about how much meat you're eating and try to eat less. Less is better, and less might lead to eventually rarely that you eat any kind of meat. Okay? But let's take the first step. Let's try to substitute more fruits and vegetables and grains and eat less meat. And one other bit of advice, and this is the kind of thing that's commented on now, is avoid things that are processed. Things in a can. Okay? Things in a box. If it didn't grow that way, try not to eat it. Okay? So maybe pasta, you could use flour. Maybe you could buy some kinds of pasta. That isn't all that bad. And cook it up and add tomato sauces. And add whatever flavoring and spices. Okay? But don't then go and buy the ravioli in the can, is what we're saying. Because when they can this stuff, they put lots of preservatives and salts and things in it that doesn't help. So simply try to eat things the way they grew. Number 2, you need to exercise. And this is what I was bragging about with Amy and I, and Amy's sitting here by the fire listening to me to talk. We take lots of walks. In fact, we take walks more than 4 times a week. And they're good walks. You get a little sweaty. In fact, on these very cold days, and we've been taking walks regularly when it's below freezing. Okay? In fact, tomorrow, right, today it's not going to get above freezing, and it's going to be one of those days we have to stay inside. But tomorrow it might get above freezing, and we expect to take a walk. And here's my point on number 2. When we start out taking a walk on a cold day, we bundle up. But we recognize that we're likely to unzip the coat and maybe take off the hat, maybe take off the gloves when we get near the end of our walk, because we're generating a lot of heat and otherwise would be quite sweaty. That's the kind of walk you want. To walk 2.5 miles, sometimes it's a 2.5 mile walk, sometimes it's 2.3 technically. for us. But to do that, it's going to take you about 40 to 45 minutes. And that's very good. Alcohol. You're trying to limit yourself to no more than 1 drink a day. Okay, got to be very careful about that. Excessive drinking is very hard on your body. And this is the point I've made already. Don't use tobacco or even vaping products. And we're starting to accumulate knowledge about the damage from vaping. E-cigarettes. I might seem passionate about this. I'm passionate because I watched my dad in the last 10 years of his life. My dad, who maybe looks a little bit like me, as you can see here, my dad died of COPD. And so did my mother-in-law. My mother-in-law didn't die of COPD. She died from smoking and lung cancer. So maybe you've lost someone who also died from tobacco. Smoking killed my dad, COPD, smoking killed my mother-in-law. This matters, guys. So a few more summaries from all sorts of organizations like the CDC down here. Diseases and health problems linked to smoking. 1 out of 3 cancer deaths could be prevented. Now, I just listened to President Biden talk about a recommitment to a war on cancer, and their goal was to reduce cancer deaths by half in the next 25 years. Well, guys, you could reduce 1/3 of cancer deaths simply by stopping smoking and doing things like abusing alcohol and other kinds of risks that lead to cancer. Smoking causes all of these types of cancer. So look, here's another, and this is now 20 years out of date, so the general trend is true, but maybe the exact numbers are varied. Leading cause of death in the United States, well, you die from heart disease, you die from cancer, you die from stroke, and then on down the line. What are the causes of these deaths? Top, tobacco. Number 2, poor diet and physical activity. Number 3, alcohol. Gosh, weren't those the factors I just talked to you about? Eat a healthy diet, a poor diet. Be physically active. Do not smoke, and limit your alcohol consumption, guys. In 2004, I went to a scientific meeting. It was actually a really neat meeting. I was invited to speak, and it was the International Congress of Vertebrate Morphology, and I was asked to talk about teaching comparative anatomy. But that wasn't my point. When I was at the meeting, I saw 2 of my mentors, 2 people that mentored me in my doctoral program. And when I saw both of them at about the same time, they were so thin, I thought they had cancer. I thought they were dying of cancer, and I gasped. I literally gasped. Oh my gosh. And I went and talked to both of them. And I said, are you guys okay? Yeah, why? Because you've lost a lot of weight. Yeah, it's a good idea. You should lose some weight. Makes you healthier. Really? Yeah. You know, you can lose weight, you can eat right, and you can exercise more. And when I left that meeting in 2004 and came home, I thought, yeah, you know what? It turns out smart people can control exercise and diet. Smart people can make these kinds of decisions. Smart people can choose to live a healthy, long life. There are other factors, genetics and accidents. But largely, the length of your life and the health that you enjoy are within your control. You need to know what you need to do, and you're in the right class. So, be smart, be intelligent, make good choices, get vaccinated, because know what number 4 is. People are dying of influenza. And this is 20 years before COVID. Gosh, think I'm done talking about smoking and lung cancer? Nope. Lung cancer accounts for more deaths than any other form of cancer. Well, why? Do we have a mechanism? Yeah, there are at least 60 carcinogens known in cigarette smoke. What happens? Well, squamous cell carcinoma is the most common. And so look, how you have the background to really understand this. Your normal bronchial epithelium, which was a pseudostratified epithelium, had all those goblet cells, gets changed into a stratified squamous. Those dividing cells do not stop dividing and they start spreading. And they cause bleeding. And they reduce the functional respiratory tissue. Here's an image from your textbook. Healthy lung on the left. This is what you get on the right. I don't know. I don't know what it takes for people to stop smoking and people to avoid beginning at all. But this kind of stuff on the right side is not appealing to me. And that would be a deterrent to me. Other kinds of lung cancer that come from smoking. Adenocarcinoma, and these are things you'll hear about because these people show up in the hospital. In this case, mucus glands of the lamina propria. Those go crazy. And the worst kind is small cell or oat cell carcinoma. And this is what I talked about already with my mother-in-law. It's the least common, but the most dangerous. It's named because of the appearance of the cancer cells. But take a look, guys, and notice what's in red. I was telling you about the mediastinum when you started dissecting the thoracic cavity. And I said it's that space right along the midline that contains the heart, major blood vessels, trachea, esophagus, nerves. And this is where typically small cell carcinoma spreads. Prognosis is very poor, guys. Okay. Often first sign is coughing up blood, and by that time, you've already got the cancer. It says metastasis, which is the spreading of the cancer cells, usually occurs by that time. And so where do we know that those cancer cells wind up? All around the heart, in the bones, liver, lymph nodes, and brain. And it's going to be really tough to fight that. Now, we're coming up with new ways to do this, but it makes sense to me that the best thing to talk about right now is how to avoid it to begin with. Avoid it and not treat it. Here's looking at the use of any tobacco product, e-cigarettes, and also high school, middle school use of these kinds of things. And what you're seeing is middle school kids, we've got a ticking up of the use of tobacco products. Tobacco products at high school are ticking up. E-cigarettes are ticking up. This is amazing to me. We understand. The slopes right here, now 7 years ago, starting in 2015, is down. But we've started back up. That is crazy to me. More things for you to see. Center for Disease Control here. Youth nicotine exposure. It's going up. Kids are getting addicted to nicotine. 1 in 5 high school kids are using e-cigarettes. This is 2018, so 5 years ago, 4 years ago. 1 in 20 middle school kids are using e-cigarettes. Middle school. So we have to talk to kids about addictions to nicotine. So what do we know about smokeless tobaccos? Some of the stuff you chew. Again, increasing the risk of, well, if you have it in your mouth, of oral cancers, nicotine addictions, other kinds of problems of the esophagus and the pancreas. All right. Here's a long list of all sorts of other kinds of disorders of the respiratory system. Table 22.5. You can take a look at this. Rhinitis is a runny nose. So acute rhinitis is your nose won't stop running. Pneumonia, sleep apnea. You hear about these kinds of things in which people stop breathing. So other disorders that are described in your textbook chapter, and I urge you to go see them. And this is it, guys. We're done. We're looking at other systems of the body, and just like the integumentary system connected to other systems in the skeletal system, the respiratory system is connected to almost everything else. Why? Because the respiratory system is allowing us to live, really, to metabolize, to use oxygen and give off CO2. So it's all connected, and it's closely connected to the circulatory system, and that's going to be a whole long series of lectures. I think there's a couple lecture exams over the circ system. It's largely what I'm going to talk about for the rest of the semester. I do have some other lectures planned, but it's largely what I'm talking about for the rest of the semester. And so this is it. This is the end of the 11th recorded lecture, but this is the last lecture for lecture exam 2. Okay? So we're done with lectures for lecture exam 2. Bye-bye.